I'll just Carissa, can I just check to see if you can see how many are in the room? We've got
Currently
57.
55 in the room with 2 in the waiting room that I'm admitting now.
Okay. So for all of our members who are on already, I'll just let you know that the webinar is being recorded, but we'll officially start in a couple of minutes. So just let the members join because we have over 200 people registered. So we'll give it a minute or two more for everybody to get in. Okay, I might start our introductions for our speakers. It looks like the people joining have started to slow down. So my name is Nikki Milne. I'm the Secretary of the International Organisation of Physiotherapists in Paediatrics, or sometimes you'll hear people call that the IOPT or the IOPTP. So today we have our ninth webinar of the IOPTP titled Advanced Practice Physiotherapy in Paediatrics, Paediatric Orthopaedics. And this webinar has actually drawn more interest than any of our webinars so far from members all over the world. And I think that the registrations have probably come from countries that are in the middle of the night as well. So many of our members who have registered interest in this webinar are likely to be watching the recordings. So on that note, I also wanted to let you know that it is being recorded and it will be available on the IOPTP website in the coming month for anybody who actually misses the webinar. You'll see that there is a QR code down on the bottom. So for anybody who needs a registration certificate, please go ahead and scan the QR code at the bottom and register. And then once you've registered over the coming month, we'll be able to get registration certificates out to you. Looks like we still do have a few people coming in. Chrissy, you're okay to keep admitting?
I'm on it.
Yeah, thank you. Okay, I'll go ahead and welcome our presenters. Thank you very much to Dr. Marie O'Meara for pulling together each of our speakers on this topic and offering this as an opportunity for our IOPTP members to present. We also have Katie Hayes, the lead advanced practice physiotherapist, who's from Scotland, and Fran Sutton, who is a clinical physiotherapy specialist, Paediatric Orthopaedics, who will be speaking to you today. So each of these speakers have wonderful experience in this space, and we will have some opportunity at the end for a short period of discussion, but each of the presentations will go back to back. please feel free to write down your comments at the time, and then later towards the end of the presentations, you can start putting the comments in, and you'll be able to have those addressed by the speakers before everybody leaves the webinar. If you have any issues with connections or anything like that, there was on your login details an email address, so I'll keep an eye on that as well to see if I can help anybody who's having problems. So Carissa and I will be working in the background for that. And I also wanted to say a big thank you to Carissa, who's taken over looking after the webinars for the IOPTP, because it is a big job and does take quite a lot of time and commitment to get everything in order. So thank you to all of our speakers and Carissa, and I will hand over now to Dr. Maria Mir.
Good evening, everybody. I'm going to say good evening because it's evening time in Ireland, but hello at whatever time you are at internationally, and thank you so much for IOPTP for having us, and I want to say thank you to Katie and Fran for agreeing to come on this with me when I volunteered us kindly when in their absence. So I'm just going to show that this is, so everybody, if you could just log your attendance with QR code. And then the important message: the material in this communication may be subject to copyright. Please refrain from copying or taking images or video footage of any material presented throughout this webinar. So just for those of you who don't know who I am Dr. Maria Mir. I'm a clinical physiotherapist. I have worked in pediatric MSK, first burns and plastics, and then orthopedics for about 20 years. And I stopped working clinically actually just last year, about 18 months ago. I completed a PhD in Advanced Practice Physiotherapy in Pediatrics based on my clinical work. I set up the Index Paediatric Orthopaedic Musculoskeletal Triad Clinic in Ireland, and I completed my PhD on advanced practice in that, which led me to a role in the Irish Society of Chartered Physiotherapists around advanced practice. And then last May, I commenced as the CEO of the Irish Society of Chartered Physiotherapists. But I think my true love will always be pediatrics. So first of all, I'm going to talk to you a little bit about advanced practice and what it actually is and what it means, because there can be quite a bit of lack of understanding what it clearly is. It's not direct access, it's not direct referral. What it is, and it's not a specific role, it is a level of practice. So advanced practice physiotherapists are highly autonomous and completely responsible for their own workload all the time, and generally manage the patient the whole way through their pathway of care without involving a referral from a medical colleague. And it does involve direct access usually as well. They assess, diagnose, and treat, often in one sitting. They can perform a number of tasks. So they may perform joint injections, they may remove POP or K-wires, they can refer for investigations such as bloods, MRI, X-ray. In the UK, and they are participating in non-medical prescribing. They can use prescribe oxygen and spirometry. They can perform ABGs and start patients on NIV, and they can fit pessaries in pelvic health. But just being able to do this task does not mean you are an advanced practitioner. The definition really of an advanced practitioner is somebody who can see a patient, say for example that needs a joint injection, assess them, diagnose them, decide that a joint injection is a warranted part of their treatment, then be able to perform the joint injection and then follow them up in their rehab afterwards. So as you can see, it's not just the technical aspect. The technical aspect are parts of advanced practice, but being able to do the technical aspect does not make you an advanced practitioner. It's your role and autonomy. So the World Physio definition of advanced practice describes them, as you can see here, highly specialized, making complex decisions and managing risks in unpredictable contexts within a defined area. They may focus on a specific area of clinical practice, education, research, or professional management. Working at an advanced practice level requires a combination of advanced skills, knowledge, and attitudes that enable the physiotherapist to address problems and manage risk in unpredictable contexts. It involves the use of critical thinking to deliver care to patients with complex needs safely and competently. It includes the ability to recognise and manage unfamiliar presentations outside an individual scope and take appropriate action. So you can see here the language that's being used. They talk about highly specialised, complex decisions, managing risk, unpredictable contexts, unfamiliar presentations outside an individual scope. So this really is the highest level of practice that we have. And there are 4 pillars in the UK and Ireland, and I believe in Canada as well. They have adopted a 4-pillar model, though I think in Australia there is a 6-pillar model, but they tend to fit into the same 4 pillars. And it's based on, the 4 pillars are education, clinical, research, and leadership. And the requirement definitely in the UK and Ireland is that you are functioning at these levels at master's level, postgraduate master's level of activity, or QQI level 9. So you have to demonstrate your competencies at master's level in all 4 pillars. So it's not just your clinical skills, and I will go through the 4 pillars. So talking about the education pillar, the education pillar is really important. And I actually was talking to a group of physios yesterday. And I think one of the key things physios are educators. We educate our patients. We educate their carers, their guardians, their families. We educate our colleagues, our peers. We educate the healthcare assistants who work with us. We educate the medical colleagues and nursing colleagues that we work with, the admin staff. But really, in the education pillar, you must be participating in both formal and informal teaching and learning. Ideally, you will be supporting students, perhaps lecturing in universities. You also need to be educating and empowering others. And we would recommend that you're participating in student, staff, peer supervision and support. We have done some research around advanced practice recently in Ireland around what managers think. And they are very concerned that as people move into these very extended scope of practice, that they stay core to their original profession of physiotherapy and would participate in teaching and succession planning with the staff coming behind them, because often they have very highly specialized skills and knowledge, and that they don't kind of move away and move off into a different medical area, but that they are they are a really integral part of the physiotherapy department as well, so that they're educating students and staff and giving this peer supervision. The clinical pillar is the easiest to associate with, especially for those who work clinically, especially early in your career. But the clinical pillar in advanced practice is very high levels of clinical reasoning, critical thinking, decision-making, and caseload management. Also, we would say very high analytical thinking and decision-making. And also to say that the indication is that around 4 to 6% of the physiotherapy workforce in the UK and Ireland and elsewhere are working at an advanced practice level. The research pillar, I'm absolutely passionate about the research pillar, and you would say obviously she has a PhD, but actually I went into my PhD and the last research I had done was 20 years previously, before the internet. We looked up articles that were bound in journals in our library. So when I say my learning curve initially was like vertical, it absolutely was. And I never went into it because I wanted to have a defined research career or anything. I just had a body of evidence I had collated in my clinic, my service that I developed, and I wanted to publish and show how important this was. But everybody should be engaging in research. If you call yourself an evidence-based practitioner, you have to be auditing. You have to be auditing your practice. If you're not auditing and comparing against what's out there, you're not evidence-based. And we do use evidence to inform our practice. When I graduated in 1997, celiacs was all the rage, and every ankle got frictioned. We have moved on from that. And even if you don't engage with research actively, you do know, even by osmosis, where our profession is moving. So it is based on the evidence and the research. And I really feel that all clinicians should be involved in this, because most research questions actually should be coming from clinicians to help inform service delivery. So you should be doing, at advanced practice level, you should be doing formal research and writing journal articles. You should be involved in service improvements, applying guidelines into practice and measuring outcomes. And again, at advanced practice level, you're expected to be having an impact that is definitely regional, if not national. And leadership. This is something I'm absolutely passionate about. And this is my favorite quote about leadership. And I think it really speaks to healthcare. Leadership is not about being in charge. Leadership is about taking care of those in your charge. It is a skill, not a role. And we in the IACP are developing a leadership academy to help our physiotherapists learn these skills. It's about empowering and influencing others, including patients, in the delivery of care. And what you can see from these 4 pillars is that none of them, they are all synchronous. You are never just working clinically. When you're working clinically, you're educating your patients, you're advocating for patients and showing leadership at the same time. You're informing them about your research. So actually it all works hand in hand all the time. So what is advanced practice and what is specialism? Specialism is not advanced practice, though advanced practice are normally specialists, but they can be generalists. So, for example, with the first contact practitioner roles in the UK, but not all specialists are advanced practitioners. It involves role substitution and traditionally techniques performed by other professions. It will require additional education and training, significant professional experience, competency development, and you must work in collaborative work with other professionals in knowledge translation and service delivery. And the easiest way to describe it is what I said before. An advanced practitioner, you are responsible for the whole of that patient's episode of care, their investigations, their treatment, their medication, whereas a specialist will just focus on a discrete aspect of the care. And anybody else who wants to read about that, this is a lovely piece of research paper, actually from Ireland, in nursing, which describes the difference between clinical specialist and advanced practitioner nursing roles. So then moving on to my research that I did as part of a PhD. And again, as I said, this was around the advanced practice clinical triage, musculoskeletal triage service that I set up in our Children's Health Ireland in Crumlin in 2010, and which is still running. So it was a mixed method study. There was audit, survey, semi-structured interviews, and economic evaluation, and descriptive analysis of statistics and content and thematic analysis. So, and all these papers are published, and if you want to contact me at the end, I'm happy to send them on, but they're all freely available as well. So the first paper was Advanced Practice in Paediatric Orthopaedics, Innovation and Collaboration to Improve Service Delivery, and that was the literature review. And it really highlighted that 1/3 of adolescents report MSK monthly. MSK presentations account for between 6 and 18% of paediatric presentations to GPs every year. So this burden is not really understood, but it is huge. A non-word referral is most prevalent in those under 4, as we know, and then in the later teenage years. At the time I started it, in Ireland, which is a population of 5 million people, there were 3,465 patients on the orthopaedic waiting list in CHI, and the average wait time was anywhere between 2 and 4 years for a normal variant to be seen. Part of the problem was paediatric orthopaedics in Ireland at the time was the most under-resourced medical specialty, and also we had the lowest rate of paediatric orthopedic surgeons per head of population in all of Europe. So normal variants make up 50% of elective referrals to paediatric orthopedic clinics, we know that, and discharge rates are anywhere between 85 to 97%. These really should not be coming in for what essentially are surgical clinics. Normal variants make up 50% of electives to orthopedic clinics. They do resolve spontaneously with growth. They do not require specialist intervention, and they are seen as unnecessary referrals to surgeons. So my initial focus and my initial remit was around these normal variants. So then moving on to the efficacy of the role. So actually, by the time we started off just with the normal variants, and they had a cohort for us to see, and we actually got through them very quickly with very high discharge rates. So we expanded the service to the point where now there actually is a scoliosis screening service, I believe. I'm not there anymore, though I do stay in close touch. But basically they manage all the non-surgical, non-lumps and bumps orthopedic referrals from 0 to 16 years of age. And it's one whole time equivalent physiotherapist in the role, and they manage more patients, new patients every year than the 7 orthopedic consultants combined. So looking at exactly the outcomes, what we know is from looking at this, 76.8% patients in the first 3 years were managed independently without any consultant intervention, excluding the DNAs. The most frequent outcome was discharge back to the GP or their physio. Physio referrals were made for 387 patients. 159 of these returned for a review or in either our own clinic or the consulting clinic, and direct referrals were only 17.8% of the patients seen. So you can imagine, another way of saying that is, of all those patients, of those 2,650 patients that were sent into orthopaedic consultants, only 17.8% of them actually needed to see an orthopaedic consultant. So what was their diagnosis after triage assessment? The most common presentation was what we call normal presentation, either a normal variant or a completely normal exam. So no need to be seen at all. Non-orthopedic patients, so suspected developmental delay, developmental coordination disorder, neurological or inflammatory disorders accounted for 4% of our patients. And we are able to refer directly to the appropriate specialities. So those consultants, be it endocrine, pediatrics, neurology, oncology, wherever we need to send, will accept referrals directly from the physiotherapists. But a lot of relationship building was required to get to that point. What was the impact on waiting times? Again, so this is published in the same study. Basically, I won't go through all the different tests we did here, but the time reduced from a mean wait time of 101.92 weeks initially to 15.45 weeks within 3 years. And there was a significant reduction in wait time year on year over 3 years. We then wanted to see, so we knew we were getting through the patients, but we wanted to make sure that we were accurate in our diagnosis. So we did an evaluation of diagnostic agreement rates between ourselves and the pediatric orthopedic consultants. So of the patients, we evaluated all the patients that we referred into them in 1 year, and we compared our initial and solitary diagnosis with their final diagnosis after they had ordered investigations, MRIs, whatever they needed to do, and seen the patient a couple of times. Our selection accuracy was 87%. So they felt like we referred in appropriately 87% of the time. We had an 82% agreement rate on diagnosis. So that was ours against theirs. As I said, it was over 113 patients. The mean age was 8.4 years. And our surgical conversion rate was 23%, which is 3 times higher than the surgical conversion rate from GPs. So again, in terms of efficacy, surgeons want to be able to identify surgical patients. So we were 3 times more effective at identifying the surgical patients that they needed to see than the referrals coming through from GPs. Then the next important thing was to see were parents satisfied. So there was always a concern would parents say, well, actually, I want to see a doctor at the end of the day and not a physiotherapist. But actually, in the whole 3 years, we had 2 patients who asked why they were seeing a physio instead of a doctor. They were clearly told they were in the appointment letter and then explained at the time. And when they were explained what the assessment was and they would given the opportunity again afterwards, none of them elected to go on to see a consultant instead. So with regards to the patient satisfaction, the satisfaction ratings were excellent with a mean total score of 95.3 out of 100. It was evident from the comments that the patients placed importance and value on how the physiotherapist spoke with the child, noting respect for their developmental level and understanding. They commented on the efficiency, the excellence of care and satisfaction with the appointment. And many patient participants expressed gratitude for the service provided. They also said that high levels of patient satisfaction were consistent with what had been reported in the adult APP. And as this was an introduction, represented a shift in service delivery, it was really important for us to evaluate satisfaction, as service user buy-in is essential for a new model of care to be accepted and sustained in the long term. And as I said, the clinic is now in its 14th year, so it really is well established. So then we looked at referrer satisfaction. So we went back to the GPs who were referring in and did a survey of them. They're still not fully satisfied with wait time. 50% were satisfied with wait time. And again, over 30% were dissatisfied. But unfortunately, and that is something that had improved, but unfortunately, our health service is not as efficient as we would like it to be. 80% were happy with the written communication received. 90% were happy with the recommendations we made. 90% were happy with the management, and 92% would said they would re-refer. And then we interviewed all the consultants across 2 sites. And we actually went across 2 sites at that stage because after I started presenting initially, another site was opened up in Cork. So we spoke to the consultants both in CHI in Crumlin and Cork, which is in the south of the country. So it was absolutely rich with detail. What the biggest thing they highlighted was our clinical decision making. This was one thing that came out in all the interviews, the clinical decision making. There was such a high level of clinical decision making. The other thing was they felt there was excellent communication, both GP communication and team communication. The challenges for them was they had concerns initially. It was an extra consultant workload for them. They felt it did lead to inequitable access at times, and they felt that more work needed to go into the referral knowledge base. And they clearly identified the different benefits, such as consultant satisfaction, community team education, because we do go out and educate the community referrers, the efficiency of care, and they felt training should be both experiential and formal. And finally, we wanted to see if it was cost effective. So this was probably the hardest part of my PhD because I do not have a background in economics. And after I'd learned everything, I had a whole new set of language to learn. So if you look at this table, really the most important thing is this is the results of the cost analysis, which takes into account both new and review appointments that took place over 1 calendar year. And when total costs for each pathway are considered by the number of contacts, we found an incremental cost saving to the service provider of 13,000 for that year in favour of the AP clinic, or 24.51 per patient. So we are 24 euros 51 cent cheaper per patient compared to the consulting clinic. And you can see the cost of a new appointment for consultant, actually, we are half the cost. So we are half the cost of a consultant appointment. So speaking about the service in general, one whole-time equivalent post managed 2,650 patients in 3 years, and the mean wait time reduction was 86.47 weeks for patients. 77% of patients are managed independently. 96% of normal variants were managed independently. There was a good to excellent diagnostic agreement rate with surgical conversion rate of 23%. Parents, referrers, and consultants are all satisfied with the service, and there's an incremental cost saving of 24.51 per patient. And what are the implications? Well, for the patient, advanced practice improves access to paediatric orthopedic services and is highly satisfactory to the patients. For the service, APP results in reduced patient wait times and volumes in a proven safe and cost-effective manner. For the profession, it supports the development of advanced practice physiotherapy roles within the health system and keeps highly experienced clinicians within the service. And for policymakers, it provides evidence that advanced practice physiotherapy improves access to patients for acceptable, appropriate, and quality care. Thank you.
Thank you very much, Marie. I think our next speaker should be able to share their slides now. Katie, are you able to access the share slide? Wonderful.
Yes, I am. You should see that just now. Has it come up?
Yes, that's it there. Thank you very much.
Yeah. And I'm going to turn my video off for this just because I keep getting this message that my connection's unstable, so I don't want it to be glitchy. If there are any issues, somebody can just let me know. But we'll just get started right now. So my name's Katie Hayes. I'm the lead advanced practice physiotherapist working in Fife, which is in Scotland. And I'm here to talk about how advanced practice within pediatric orthopedics has a role in transforming models of care. As Marie explained in her presentation, advanced practice is about a level of practice. It's not just a job title. The concept has been around since the early to late 1990s, and our adult MSK colleagues are much farther along this road than we are in pediatrics. I don't think it is fully understood all that we as advanced practice practitioners have to offer pediatric orthopedics in other areas or in the future. So as a quick introduction and to explain my background, in case some of you have picked up that I don't sound very Scottish, I grew up here in Illinois, and I went to school at St. Louis University and qualified in 1989. For the majority of my career, I have been working in pediatrics, although I've dabbled in and out of adults, depending on where I was. Spent a couple years working in Zimbabwe, and then I came to Fife, which is this area of Scotland, in a roundabout way. I'm obviously going speaking from my experience working within the NHS in Scotland, but I'm part of the Advanced Practitioner Peer Support Group with Marie and her different colleagues in Ireland, England, and France, part of it in Northern Ireland. And we've got, so it's quite a big group. I work between these two hospitals in Fife, and there are district general hospitals, which I'll just explain a little bit more about as we come. So why do we need to change? And why am I keen to promote what advanced practice has to offer? Because especially in the NHS, the current system just isn't working. And in Ireland, you know, waiting for a child to be seen for 2 to 4 years with those waiting list numbers, that's just not a good service, and we can do better. And I think Marie's, you know, absolutely shown that we can. And if things were difficult before COVID hit, they became even more difficult. And I don't think it's just going to magically get better. And sometimes if we want different results, we have to do things differently. Waiting times for outpatient appointments, elective surgery were so high. So we needed to do something different. And a lot of the evidence that Marie's shown and that Fran has shown and myself, this isn't just a new concept that we think is a good idea. This is something that we have shown to been working for a while. In the United Kingdom, there are lots of political drivers, policy, and guidance documents supporting the need to transform models of care. GIRFT, which is getting it right first time, realistic medicine, modernizing patient pathways have all been in existence pre-COVID. So again, this wasn't a new idea. The report from GIRFT states that specialized physiotherapists can perform many functions within a pediatric orthopedic service, such as Ponseti casting, care of harnesses and splints used in DDH treatment, and the assessment and management of routine patients, such as variants of normal. In another part of the report, they go on to state that units that were actively pursuing good practice models had a mixed workforce, integrated screening programs, and true MDT working. So this isn't about physiotherapists pushing ourselves onto our medical colleagues. This is medical colleagues recognizing that we have the roles and the skills to help them. Because again, MDT working. Modernizing patient pathways promotes the use of active clinical referral triage and patient-initiated review, which I'll expand on a little bit more. And all of these have similar themes. And it's this rule along the bottom, which is shared decision-making, a personalized approach to care, reducing harm and waste, reducing unwarranted variation, managing risk, and improving outcomes for our patients. So with transforming models of care, a common theme in these initiatives is moving away from a system where all referrals are vetted by a medical consultant, all referrals are accepted onto ever-growing waiting lists and eventually seen, and in many cases discharged after one appointment or review just in case. Not only is this not sustainable, but it isn't needed and the best for our service users. What if our models of care looked like this? With active clinical referral triage, this supports enabling better referral pathways and access to information to avoid unnecessary referrals. Some studies, as Marie was talking about, show that normal variants make up over 50% in the pediatric orthopedic referrals and clinic appointments. In Fife, through our service redesign that I've led as an advanced practitioner, and again, a nod to Marie's leadership, audit, and research pillar, we have been able to reduce that to under 3% of referrals, and we appoint even fewer. ACRT designates a senior clinical decision maker rather than always being a consultant. Best management isn't always an appointment, but if it is, it doesn't always need to be face-to-face. And it is possible to do something thoroughly do a thorough assessment virtually, as we all learned in COVID as we had to adapt. The outcomes can be wide and varied, but another ACRT component is patient-initiated review. Come back if you need to. We've been doing this in Fife for over 2, now 3 years, and I'll speak about the impact on that just shortly. So the scope of possibilities. What if models of care looked like this? Sorry, there we go. This slide demonstrates not only the scope of what's possible, but what has been happening for years, but unfortunately only as pockets of practice in certain countries rather than as the norm. As you can see from the first 4 slides, the baby hip and the baby hip foot service, Fran will be talking about that later. My focus is the general outpatient clinic and with neurodisability, but please look at the 5th column over there, which is a service responsibility. And this is where the leadership comes in. This is where the research, the audit, and the education. The pediatric orthopedic service in Fife has been led by advanced practice physiotherapists since 2016. As I said, we are a district general hospital, and the easiest way to explain that is a smaller county hospital. It's not a tertiary center. We have an orthopedic consultant in Fife 1 day a week to do 1 afternoon clinic and give clinical support to myself and another advanced practice colleague. A significant part of my role and remit is on non-clinical and on service delivery. I'm proud to say that we have a successful service with low waiting times and high satisfaction rates. In terms of a quick background of how we got there, sometimes things just happen. In 2005, our orthopedic consultant retired and an orthopedic physician was appointed. Myself and another colleague were brought in to support the orthopedic physician in 2008. My role and remit was a general orthopedic and focal spasticity management in children with neurodisability. In 2012, as I was doing more with focal spasticity, that evolved to I took the whole service for managing our children with neurodisability from an orthopedic perspective. And then when the pediatric orthopedic physician retired in 2016, myself and my colleague were upgraded to lead the service. So we also, in addition to having consultant support orthopedics, we also have consultant support from our radiology colleagues. So again, quickly just looking at my role and remit in terms of, again, focusing back on what Marie was saying in terms of the scope of managing the entirety of the patient and being able to order investigations. I can request x-rays, MRIs, ultrasound scans. I can also request and take bloods if I so need to. But we also now have excellent nurse or therapy support workers that are much better at it and do it all the time. But again, as I've said before, the day-to-day running of the service, the vetting and triaging of all the referrals, making sure that the service user information is available. We've got a letter tag, we've got QR codes, we've got referral guidelines, we've got our web pages are up to date. We do lots of teaching and training. And from a service improvement and audit, quality improvement and governance, if you don't count, you don't count. So I know we're clinicians and that is where my heart lies, but you need to have evidence and there's no way of getting around it. So again, some people might look at that and say, oh, your data is from 2018. Well, yes, our data is from 2018, and it shows that 6 years ago, we were having excellent results. And of the 601 patients referred in 2018, 10% of them needed consultant review. Only 1% needed to be referred on to the Children's Tertiary Center, and 4 of those kids needed surgical intervention. So if you look at that infographic, you can see how much of the service we as advanced practitioners are able to manage. Again, my information and my data aligns very much with Marie's, who again, tertiary background versus a district general hospital. So again, our scope and possibility of this being applicable is in all areas. It's not just in small areas, small hospitals, or it's not just in specialist hospitals. And again, our statistics, if you don't count, you don't count. In 2023, I saw 83% of the patients independently. I had to discuss 15%, and we had joint appointments with 1. Review appointments were fairly similar, and management of the results. I managed, of my x-rays and MRI investigations, nearly 70% on my own. In terms of patient-initiated review, I spoke about this before. So 354 patients were discharged to patient-initiated review since 2020. 2 in 2020, 23, and you can see how our numbers were increasing. And this is sometimes scary, especially with children. You just want to be sure you know what's happening. But what was happening is, because we were hanging on to all of these kids just in case, our review clinics were so backed up, and we didn't have time. We didn't have a timely service that was reactive to our patients' needs. All families are copied into clinic correspondence, and because how can you expect a patient to manage their care if they can't remember what they were told at the clinic? So by doing those service changes, and this is what would, families have it verbally in the clinic, and they also have it in writing. This is what you would need to do. So our return patients, as you can see in 2022 and in 2023, I'll get my 2024 data in the next few months. No pathology. Never say never, but if you can look at our review times, our 8-week wait time is now 1 to 5. Our referrals have also significantly dropped since I've been able to do some of the service improvement. Our service user feedback, again, very high. So this is 94, 95 out of 100. We created something with MS Forms to gather service user feedback. Not everybody really knew what a QR code was, but if there was a silver lining of COVID, I would probably say that QR codes are one of them. One of the questions asked who they were seen by, and 82% were from people that had seen myself. So again, they're rating the service very highly over the years. And again, I'm going to get my 2024 data soon. But it's not just about the clinical role. It's, as Marie was saying, and this is what we're talking about in terms of incorporating the other pillars. So you can't manage anything unless you have the information. And this is where the audit, the research, our new patient referrals have decreased by 30 to 40% since I came into post. Our review appointments have decreased by 50%. Our normal variant rates are now under 3%, and our waiting times are between 2 to 4 weeks for an urgent patient and routine under 6 weeks. But all of these different components, the letter tag, the referral guidelines, the website information, that's all the service role that I've done as an advanced practitioner. And there's not anything particularly special about myself, but the consultants wouldn't have had time to look at this because they are absolutely flat out just firefighting all the time. And also, surgeons want to operate. That's kind of why they spent all of that time training to do that. So it's about the MDT. So let's let the surgeons do what they want to do. I think as physios, we are so much more tuned into the needs of the child, the needs of the patient, the needs of the family. And I think we spend a bit more time explaining things to families. And when they know things, then they've got that information. So in terms of impact, like I said, waiting times down, the anesthetic costs, again, cost savings. And this is old data, but we've showed this, well over 10 years ago. When I started working in the focal spasticity service, all of our children had it done under general anesthetic. But with the training that I had done in terms of being able to inject under ultrasound and under topical anesthetic, our numbers stayed static over those 5 years, but our kids going for a general anesthetic dropped from just below 80% to 16%. So we're able to calculate that every time a child went for general anesthetic, that added 800 pounds worth of cost onto the procedure. So in those 5 years, we were saving just between 20 and 25K in general anesthetic costs alone. I would have loved to said that they pivoted that money into our service, but they did not. Decreased travel times, patients are seen closer to home. They're not being sent to the tertiary center. increased capacity through patient-initiated review, which I've already spoken about, better links with tertiary centers and board areas. I'm actually doing, I'm helping out another one of the board areas in Scotland. Their orthopedic consultant is on maternity leave, so I'm covering her clinical load. And an improved care pathway, because I've been doing this for a long time and you need a little bit of variety. And so I thought this was really, really good. I think change is a good thing. And advanced practice, and this is again what Marie was talking to, it's about evidence, it's the pillars of practice, it's the capabilities and the competence, it's absolutely governance. You know, absolutely. And we need to have those strategic bodies making sure that we are safe and that we are trained and we have the appropriate level of training. And also again with the political drivers. So even though Marie's shown that we are half the cost of that, it's not just about saving money or we're cheaper replacement medics. We bring our own skills to the job to widen the scope of provision for our service users. So again, Marie was able to demonstrate all of this with her evidence, decreased waiting times, that we are safe and effective, cost savings, and service user satisfaction. Again, this is a summary of all of her evidence, but also with the development of the botulinum toxin service that was a cost savings. I'm not going to go through these because I am conscious of time, but this is being recorded so people that haven't been able to see it will be able just to have this. I think this was, you would have seen this slide in Marie's presentation, and this is about evidence. And this is, the different colors are common themes, which are similar to the components of advanced practice that I mentioned earlier: training, communication, clinic setup and process, benefits, health system factors, challenges, skills, and competencies. And this really falls under the theme that I was talking about governance. We absolutely have to have governance. And I think our medical colleagues get a bit twitchy about, well, how do you know that you're trained? Where's this training lie? And I think this is something that we have to hear them and we have to be able to give that evidence. Competencies, mitigating risk, safety, has already been an extraordinary amount of work done in the last few years that aligns with these common themes. But and I know that in Ireland, that's what Marie is working on. It's taking shape and direction, but there's nothing specific to pediatric orthopedics to remedy that. But we are on the case for that. I'm going to show it really, really quickly because I have an audience all over the world. If you have a child in front of you for whatever, a sore foot, a sore ankle, developmental delay, for the love of God, please take the 2 seconds to look at their back, because these children showed up in the orthopedic clinic with this. So if you don't know how to do the Adams forward bend test, please learn how to do it. I hate surprises and I like to sleep at night. And I would have absolutely just felt awful if this 6-year-old rocked up at 14 with this. So that's my plug for the importance of screening. My takeaway message is, I repeat stuff not because I'm old, but it's worth repeating. If you don't count, you don't count. And insanity is doing the same thing over and over again, expecting different results. We have to find a different way to work and deal with these patients that are waiting. And if nothing changes, nothing changes. And to quote Marie, you can see it here, I'm not saying we are the panacea for everything, but innovative multidisciplinary solutions are required so that the onus is not solely on the physicians to provide all the services. And we might be part of that solution. So in conclusion, to use GIRFT, rather than pediatric orthopedic surgeons, let's talk about services, and let's talk about the services being led by a multidisciplinary team with advanced practitioners and non-surgical cases, not just normal variants. Thank you.
Thanks so much, Katie. Fran, are you okay to share your slides?
Yeah, I think Marie's actually just going to share them and hand over.
And just a reminder that we'll have time at the end for some questions. So if I've certainly got lots of questions I want to ask, so I've been writing them down. So please write them down, and we'll have time at the end for you to either pop them in the chat or for you to switch your cameras on and talk to them.
Perfect. And then I think she's actually going to hand over control. Fantastic. Thank you. So, yeah, thank you very much for asking me to talk to you today. My colleagues have very eloquently given you an overview of the evidence base and some of the drivers that have been instrumental in providing the stimulus to support our roles as advanced practitioners. I'm, as Katie said, going to talk a little bit more about the role of advanced practice in baby orthopaedics and in the neonatal sort of area. And I'm actually going to look at a working model of how advanced practice can be utilised or is utilised in a typical clinic in the UK setting. What does the role look like working across the 4 pillars at ground level on a day-to-day basis? And for the purposes of this example, we're going to look at our neonatal foot deformity clinic, the Talipes Clinic, providing a service for the assessment and management of babies and young people with congenital foot deformities. So by way of introduction, I've been working in orthopaedics and musculoskeletal medicine for more than 30 years now. My journey started at the London Hospital, or as it is now, the Royal London Hospital, and similar to my colleagues who've spoken before, has taken me on a journey through a number of places. My initial paediatric training was at the Children's Hospital in Sheffield in the early and mid-90s. And since 2010, I've been working in an advanced role at the Norfolk and Norwich Hospital, which is in Norfolk, which is, Katie's up here in Fife, I'm right down here in the east of England. When I started training, any specific training for paediatric orthopaedics in this country was quite sparse, more sparse than it is now. And I was very lucky to be able to have a couple of spells going across to the Royal Children's Hospital in Melbourne, and undertook the specialist certificate there in paediatric orthopaedic physio, which was a fantastic course and gave us some invaluable insights. So, I think there's a lag, bear with me. Okay, so to expand slightly on my current role, really it comprises of 4 clinical areas. In conjunction with my colleague, there were 2 of us appointed as 2 whole-time equivalents across our region, with 1 work-time equivalent based at the tertiary centre and 0.5 of each of our roles, so 1 full-time equivalent across the region. So we have a hub and spoke type network to provide specialist services close at home for the families in our area. And also this helps to maintain and develop the skills and the competencies as local staff that we were working alongside in those DDHs. So we run normal variant clinics. These initially started out as sort of a very typical normal variant caseload, but have with time expanded to include all of the sort of non-surgical, non-trauma type cases that are referred into the paediatric orthopaedics caseload. And over the last 14 years, between us, we have seen over 13,500 patients that we have independently managed in that time. A second role has been within the baby foot deformity clinics. Again, this is run on a weekly basis across 3 sites in the region. We manage and treat the babies with Talipes, but also other congenital deformities. I'm going to look at this at service in more detail. We have physio-led DDH clinics, not just providing part of the one-stop screening service and managing the babies that are in harness, but we also have the ability to carry out ultrasound scanning, and we carry out the review appointments up until the point of discharge for those babies that have been treated in a harness. And then my final role is in the paediatric spine service. I've been part of the spinal deformity team for some time, and we're also in the process of setting up paediatric spinal triage clinics as part of the wider regional children's spine service. So why baby orthopaedics? Well, as with many of paediatric orthopaedics, it's something that has a very large non-surgical element with the treatment of talipes, the management of children in harnesses, and so is eminently suited to our roles. It's an area where support for the families is a fundamental element, and I believe that this type of work plays hugely to our strengths as therapists. In particular, and as has been mentioned earlier, our communication skills and the fact that we often have more time than our extremely busy orthopaedic surgical colleagues means that we are a fantastic resource in these clinics. We have a growing body of evidence that can support the findings that functional outcomes and patient-reported outcomes are on a par with those in consultant-led and consultant-run clinics. And a few references for these will be put at the end. So midterm results of a Physio Ponseti-led clinic, sharing care in hub and spoke type services with physio-led Ponseti clinics. Sorry, there's a bit of delay. And the midterm, the opposite way, midterm results of physio-delivered Ponseti service for management of clubfoot. We also, as Katie has alluded to, have a number of strategic drivers that are supporting the roles of physios in leading and providing this care. But as we said, advanced practice is more than just the clinical care. It's across 4 pillars. Definitions may differ slightly in our different countries. And even, as you've heard from Katie, the wording can be different in the different countries that make up the United Kingdom. However, there are certain core elements that are the same. The fact that it's delivered by experienced practitioners, the high degree of autonomy that is involved, and the complex decision-making. The care managed in partnership with patients and families, the synthesis of complex information, and being able to derive innovative solutions to get the best possible outcomes. So we're going to consider a typical patient journey that provides evidence-based gold standard care to a baby born with a condition such as clubfoot and supports the baby's family. We're going to discuss how our clinic model utilises advanced practitioners demonstrating our responsibilities across all 4 pillars to ensure the best practice for our patients across our region. The clinical role splits into a number of components, and we're actually going to talk about these in a little bit more detail and how they relate to our various advanced practice competencies. Also, the importance of the support and communication role that we have already alluded to. But as my colleagues have already pointed out, and again I stress, it's not only a clinical role, and an excellent clinical service cannot be provided without a number of other factors. We need a robust governance structure. We need a strong evidence base and the ability to seek out new developments and make sure these are integrated into our practice. There needs to be good leadership and management. We need to be looking at our outcomes, reviewing them, and actually acting on any findings that's coming from it. And we need to be participating in ongoing learning and development. So, coming back to our patient journey, the journey frequently begins before the baby has even been born. In our unit, we will receive referrals directly from the fetal medicine team for babies with skeletal abnormalities that have been detected on the antenatal ultrasound screening. This can be for conditions such as talipes, but may also be for congenital upper or lower limb deficiencies or deformities that have been noted. This obviously is a very difficult time for families, for expectant parents. Often there are difficult discussions and high levels of anxiety, as well as high levels of uncertainty. Until the baby is born, an abnormality may have been picked up on antenatal screening, but we do not know the extent of the abnormality. For example, we don't know whether it's going to be a positional or a structural talipes until the baby is born. And these type of patients are offered the chance to come in and speak to us about possibly the implications and what treatment may or may not entail. Obviously, in such an emotional and potentially stressful time, communication skills are key. Having a sound knowledge base of the natural history and the potential treatment pathways of the type of conditions that we may be looking at, and being able to talk through realistic expectations for the families. Or I think there's a little bit of a time left. For babies that are then born, we'll frequently receive our referrals direct from the delivery suite, direct from the neonatal ward, possibly even at times from the delivery suite. The instance of talipes or CTEV, congenital talipes equinovarus, is approximately 2 per 1,000 live births in the UK. And the majority of the babies that we see in our foot deformity clinic have some form of talipes, whether this be structural or positional. However, we must ensure that we confirm the diagnosis and that we use our surgical sieve to differentiate between a number of other abnormalities that we also get referred on an infrequent basis from the postnatal wards. We need to be able to differentiate, for example, between babies with a rocker bottom foot and a severe calcanea valgus foot. We may get children with posteromedial tibial bowing. We have various forms of fibula, tibia, hemimelia in a more severe form or in a milder form with absent rays, and babies with congenital knee dislocation, albeit rarely. We will often be the first person that can be called up to go and see some of these babies. It's also worth reinforcing at this point that whilst many cases of talipes are unassociated with other conditions and are primary club feet, there's a proportion of babies with secondary club feet or vertical tali that are related to other conditions such as spina bifida and arthrogryposis. This obviously has many other implications that need to be considered and reinforce the importance of working with our wider multidisciplinary team. In these instances with the babies that we're seeing, not only are we forming our diagnosis of what's going on, but we also then start to request any necessary investigations, such as ultrasound screening of the hips, and in the more complex deformities, ensuring that a time-appropriate consultation with the orthopaedic consultant is organised. As I mentioned earlier, the birth of a baby is an emotional and exciting time, but an unexpected or even an expected deformity that was picked up antenatally can massively amplify anxiety and worry levels. Being able to assess the situation, in addition to being able to provide a thorough examination of the baby, is a vital skill. And being able to make an assessment of the parents' anxiety levels, I guess, is hugely important too. From my experience, there are often two huge concerns at this stage from the parents. One is a feeling of guilt, particularly from the mother's side. What did I do wrong? Did I cause this? Have I done something or not done something? The second is often what the future is going to hold for the child. Being able to be calm, collected, and empathetic is important, but also being able to convey information in a manner that parents can understand and that is not overburdening them with unnecessary detail at a first consultation is a learned skill that comes with time and experience. It's important to try to allay fears and concerns, but at no time must we create any unrealistic expectations. The practitioner needs an in-depth knowledge of the natural history of the conditions in front of them that they're encountering, and also needs to have an in-depth knowledge of what treatment may be indicated. Okay. As I'm sure many of you will know, a specialist clinical skill set is required to carry out the Ponseti treatment for club feet, both in the corrective and in the maintenance phase. Again, I cannot stress enough the importance of good communication skills to support the family through this process and to try to ensure compliance, particularly at the toddler stage in boots and bars. For those of you who aren't familiar with clubfoot management, the Ponseti technique is widely regarded worldwide as the gold standard treatment for congenital talipes equinovarus. It's a minimally invasive approach, hence the eminent suitability to APP-led clinics, that involves weekly manipulation and serial casting of the affected foot or feet. When the foot reaches the appropriate stage of correction, a percutaneous tenotomy of the tendo Achilles is required to enable the last part of correction and the foot to be taken into dorsiflexion. In this country, this is almost exclusively performed by an orthopaedic consultant surgeon. However, there is at least one centre where a training programme under direct supervision of the orthopaedic consultant has been undertaken, and it's now performed by the advanced practitioner in that site. Following the tenotomy, further casts are applied to maintain the Achilles length and to allow healing before the maintenance phase is entered. This is equally important as the corrective phase, as we know that the recurrent rates are high if the foot abduction brace is not adhered to. And we then continue to follow the child up once they're out of their boots and bars, during growth, and looking for loss of flexibility, looking for muscle imbalances, being able to link in with orthopaedic colleagues should further surgery be needed, and continuing with a normal physio type strength and conditioning. But as we've said, and as has been stressed all the way through this evening, it's not only a clinical role. Looking at the remaining pillars, education and training is a large part of my workload. Not only self-education, but educating our wider team and developing our team, educating those in the wider multidisciplinary team, the nurses on the neonatal unit, the midwives. We're involved in teaching the registrars on the FRCS programme. We participate in our local and national special interest groups for the management of foot deformities, and also teach as part of the faculty with Global Clubfoot International. As part of this, and we'll come on to in more detail, development, I've started along with some of my colleagues in our regional operational delivery network to develop competency and training logs for some of our specialist clinics. These look at a number of competencies, clinical competencies that are required to be working in the clinics, but also encourage reflective practice and a mentoring process to ensure that we are providing the standard of care and providing the training to get people to the level that we need to provide the care we aspire to. Training and education in terms of personal development and keeping abreast of current research, and also attendance at national or international meetings such as BizCos, Current Concepts, Manchester Clubfoot Conference. So a few examples of these, and this is the training log that we've been using. The idea is, at the moment, it's not an electronic log, it is printed off, but whenever we have conversations in clinic with some of our staff members who are learning and developing, we will have mentoring conversations, there will have key learning points, and there's areas for case studies, for example, within that too. We also have study pods across the region where we can discuss difficult cases, complex cases, or call on a friend if we just want a different pair of eyes, or if somebody wants help with something. Within the leadership and management pillar, we're involved with our clinic setup and how that's run. We have written the trust guidelines for the management of talipes and various protocols and pathways, including standard operating procedures for the things like the tenotomy to be carried out under local anaesthetic in our clinic room, protocols for ensuring that ultrasound scanning is part of our workup where we've got a baby with a structural foot deformity. As mentioned before, we've developed competency packs and training logs to ensure that staff are getting the training that they need and looking at our staff mix within the clinic. And this also helps with our succession planning and with managing staff development. And as part of good leadership, facilitating that networking of the whole team across the region and wider. And in the event that there was any adverse incident, for example, a rub or a sore, or a complaint about anything, then instigating the appropriate way of dealing with that. Not only have we set up our protocols for guidelines for the management, there's also things like ensuring there are appropriate protocols for requesting radiographic investigations and ultrasound scanning. Research and evaluation, as Katie's pointed out already, if you don't count it, it doesn't count. And part of our routine clinic is involvement in maintaining our local databases to collect statistics regarding both process and outcomes. And not only collecting the information, but interrogating that information regularly so that we can evaluate our service and identify areas for improvement. The Clubfoot consensus guidelines state that we have a duty to collect and analyse our data. We also have a professional responsibility to ensure that the level and scope of practice we're providing, and to this end, the ongoing data collection and audit is an important tool. We routinely collect process information, such as our numbers of referrals, the type of club feet that we're seeing, whether they're primary or secondary, whether antenatal counselling has been provided, Pirani scores at outset and as we go along, number of casts pre-tenotomy, any adverse occurrences or slips, details of tenotomies, number of casts post-tenotomies, adherence data for boots and bars, signs of recurrence, need for further tenotomies, and need for tendon transfers. In addition to the process information, we look at outcome data, such as patient-reported outcomes, functional outcomes, and objective measures. We use validated methods, such as Pirani scores, PBS scores, Roy scores, or Oxford foot and ankle scores, and we use simple functional objective measures, such as the ability to squat with the heels down, lunge test, and single leg balance times. At a clinical and governance level, this data is used within our unit, but it's also collated across our region within our regional delivery network to look at consistency of practice and to ensure that we're all maintaining high standards consistently across the region. It helps to identify possible training needs or areas where support or staff support may be needed. And it's really important that this is shared in a very non-judgmental way and utilised to help stimulate discussion and shared learning experiences. From a leadership and clinical management perspective, it's very useful in guiding pathway development and in planning our staff training and staff mix. And finally, within the research and evaluation peer, actively seeking out recent advances in the evidence base and disseminating this with the team, ensuring that as an individual, we are abreast of current research and publications and taking an active part in research projects as time and opportunity allows. Attending national and international meetings and ensuring that we have protected time to do this is an important part of managing the clinic well. So being involved in collecting information to help with looking at the core outcome set for outcomes of CTV guidance, ensuring that we are adhering to meeting the consensus guidelines set by the consensus group through BizCos, and attending and being involved with international conferences. I like to think of the 4 pillars not in isolation, but as part of a larger, bigger picture. Elements from all the pillars have commonality with each and every one of the other pillars, and are all ultimately vital as part of our role to produce our desired end result. From a personal perspective, working in an advanced role has enabled me to shape and influence the service that I'm part of and proud to work in, and helps to give immense job satisfaction. But what of the wider advantages and benefits? From the orthopaedic consultant viewpoint, it frees up their time from non-surgical interventions to concentrate on the surgical cases. This in turn reduces wait times. This type of clinic promotes healthy multidisciplinary team working, and ultimately, by freeing up the consultant time to work on the surgical cases, gives financial gains for the hospital. For physios, it's good for career progression and gives high job satisfaction, which in turn is good for staff retention and staff recruitment. For patients, we're ensuring that we're providing a gold standard service with ongoing monitoring and evaluation to keep the consistency and the equitable results across our region. And for families, I think the level of communication and support, the time that we have as APPs, as opposed to the lack of time that our consultant colleagues often have for difficult conversations, and for ensuring continuity and building rapport with some of these families who are going to be part of our service for a long time. And we often form that first point of contact when parents are struggling or they have an issue. They have somebody that they can call, phone a friend, and generally getting in quickly and being able to allay their fears and sort out issues promptly reaps rewards in the longer term. I believe that our system is a win-win situation. I appreciate it's different in different healthcare systems, and that different healthcare systems are funded and set up very differently. But certainly I think this model is working well for us. Just a few references there. Thank you. I think we are over to joint questions.
Thank you so much, Marie and Katie and Fran, for all of the content that you've shared with us on advanced practice physiotherapy in paediatric orthopedics. It's ignited lots of questions, I think, from people. I can see the chat was starting to get going with questions, but if people do have questions now regarding the content delivered in the webinar today, then feel free to put it in the chat, or if you want to turn your camera on, that would be even better, because we love for these networking opportunities at the end of the webinars to be active and engaging if possible. There was a couple of questions around entry-level curriculum. I do want to just let you know that a project was funded through the IOPTP for developing entry-level paediatric physiotherapy curriculum. And that went through a process over a couple of years of repeated Delphi rounds to get consensus on what needs to be included in that. Those Delphi rounds have closed, and the project team are in write-up mode for that at the moment. So look out for that to come out in 2025. In terms of the line of questions, I'm just looking at, sorry, they're starting to come quicker than I can catch up with. Just give me one moment.
Sorry, Chris, so just as you're, rather than me typing slowly, but as you're looking for themes of stuff, I think one of the things is about where should we start? And I think it's trying to figure out how to talk to your orthopedic consultants. And some people you can, I think, pick your allies, and that's a huge thing with leadership. Pick your allies. Don't You're not going to be able to change everybody, but start small and keep, find a problem that needs to be solved and go from there. But orthopedic consultants love research and they love to quote research. And I think that's how I got to know Marie, because I saw all of her papers that she was publishing. So I just adopted her as my new bestie in COVID and just emailed her and said, like, how do I do this? What do I use this? Fran's put some number of papers up and different things like that. Use the evidence. So it's not personal, it's evidence-based. And those papers are available. We've all got our contact details in this, and show them to the consultants and start small. I mean, the three of us have been doing this for a long time. And yes, now at the back end of a 20-minute presentation, it looks really, really slick. But that's not the countless hours and the hard work and banging your head against a wall and screaming into a pillow and being so frustrated. It takes a long time. And so you need to find your group, you need to find your tribe, and you need to find where you can get support from, but use the evidence. So I'm going to get off my soapbox and let you start filtering some questions to us.
Yeah,
No,
I would follow on exactly what Fran says and go for the small, easy win to start. Like, so this is all about, like, it is about evidence, but it's also hugely, and show them the evidence, because that's what they're interested in. But the next step is trust and human connection. They have to trust you as a clinician. And if they don't trust you, the biggest issue we had, so in training in Ireland, so when they're training orthopedic surgeons and rheumatology consultants as junior doctors, they're not ever allowed to see a new patient fully independently. They have to present every single new patient they review, apart from fractures, to the consultant at the end of clinic. That is their training until they are consultants themselves. Even if they're specialist registrars or fellows, they always have to present. And suddenly I was in a room next door seeing 800 to 1,000 patients a year and discharging 80% of them and not presenting any of them to them. So they literally came to me and said, "What are you doing in that room?" So we had a full open door policy where they just walked in and out and watched me assess. And I said, just come in and watch me assess. I also gave them feedback all the time. I gave them quarterly updates. I presented case studies. I presented we talked about stuff. What would you do with this? What would you do with that? So they quizzed me, but they also walked in all the time. But I also went for the very easy win. I only did normal variants until we cleared the normal variants, which is, like, for us, like, it is so straightforward. And actually it's wonderful because we have the time to give half an hour to talk to them ad nauseum about the shoes or whatever, whereas consultants are just like, in, out, yeah, they're fine, just go with. Whereas we can, like, explain it to them and get buy-in. And once we went that, then we went to knees. We said, look, give us the Osgood Schlatters, give us the Severs, like things that they were like, yeah, physios know how to manage this. Until it got to the point where, like, we actually had to stop them because they were trying to give us the road traffic accidents and the complex pain. And we're like, nah, you can keep all that stuff. So but it is about building trust with everyone, and you have to build trust with everyone. It's not just the consultants. The nurses were very threatened initially. You need absolutely, if you're going to be doing all this, you need really, really good admin support to type those letters for you. Like, I dictate, they type them, to do the booking system. So you have to bring all them on board, educate even the people at the front desk. Yes, this person is for me, not for the doctor. Like, it brings all your physio communication skills to their highest level.
Marie, may I ask, when you are kicking off, obviously it comes down to relationship building initially to get people on board. But even before that, to think that you can start it, I'm sure a lot of the participants in the webinar today are thinking, how do I even initiate that? Like, how do I start it? Do most of these, in my experience, certainly here in Australia of reviewing a lot of ethics applications, are that a lot of these things start under a research project and under ethical guidance and
yeah, no, I did it completely backwards. So what happened actually was, and in fairness, it was our consultant, we had a new consultant and she led this. So she was watching what was happening in adults, and because she had an adult feet cohort and was watching what the adults were doing, and she was really concerned with the waiting times. And she was like, surely we can introduce this for normal variants. And she had found a paper and she read it and she came to us and she said, could you do this? And actually, just to go on the story, so there was two children's hospitals in Dublin at the time, the national, and one, the consultant said, absolutely, our physios can do it. And the other hospital kind of said, over my dead body, will a physio see our patients? So there was like a competition between the two of them. We were both given the money for a pilot for a year. And we were given the physio led team, and then they hired a registrar fellow for the other one. We got through 865 patients and he got through 210 or something. So we did get a lot of support because they wanted to win. They wanted to prove that they were right. And then, but once we got through that volume, suddenly it was hilarious. I was in meetings with the CEO and nursing director. It's going, what else will you take? Like, we'll give you more staff, give you more money. And then because we know our job is about quality of care and improving function and people's lives. But what Katie said is so true. If you don't count, it doesn't count. Nobody higher up cares about.
Yeah.
They pay lip service to patient satisfaction and patient involvement. They care about numbers and waiting lists.
Yeah. Okay, great. Thank you. And Katie, I see you've got your hand up. Yeah.
Yeah, I'll just come in. I think again, it's kind of that, which way do you start first? And I think, Maria, I mean, as physios, we're very pragmatic, practical people, and we see a problem, and we do that all the time in our practice. We're problem solvers, and we are so directed on patient care, making things better for our patients. And that's how this grew out of. And if you start from the very beginning of keeping track of your information, and Maria kept track of her information, and somebody said she had so much information, there's a PhD in this, so that's where she got all of her information. It is so hard to go back and start auditing retrospectively, and technology is wonderful. I use MS Forms, and as soon as my patients walk out the door or at the end of my clinic, I complete my own MS Forms for the age, the patient. I see all of their demographic information. So I'm getting that information all the time. So that's how I can pull up my stuff on my slides. So sometimes finding a problem, offering a solution to that, but from the very beginning is keeping your numbers, and then it can grow from there. So that's what I would say. So, and then you can start to apply for the research fellow, or you can say, I'm doing this. And then you can start looking at training, and whether that is a master's program or I know Fran and her colleague went to the other side of the world to do some of that. So not everybody has the wherewithal for doing that, but there are creative ways to think about doing stuff, and everything's online again, yay COVID. Yeah. So Fran, you had your hand up.
Yeah, and I think I was going back to a comment that one of you guys made earlier, spending time with your orthopedic consultants and building that trust. I think when they do see you working and you work alongside and close, they are amazed at the assessments, the skills that we have as physios. And until they're working in a situation and they see that, they don't know. They don't know what they don't know. And yeah, that building communication and building trust with the colleagues that you're working with is key.
I think what helped me as well was I was in Ponseti as well before I started this clinic. So in our Ponseti clinic, it's crazy, but it's one big room with multiple curtains, real old hospital. So we would multiple assess each other. We'd be crossing over. We'd have the children walking up and down. So that consultant was so used to seeing me doing gait assessments that it wasn't a massive leap of faith. She was like, okay, well, Marie knows feet and she knows. So it wasn't a massive leap of faith. But as regards, yeah. So I basically collated data for 3 years, and then I was told to write it up, and I hadn't the foggiest. And there is a research wing attached to our hospital. So somebody put me in touch with a statistician. As I said to Katie, she said, if you write this up and you don't get a master's, because I literally had 2,600 and all I had was an Excel spreadsheet. That's all I knew how to do. And I had an Excel spreadsheet with every detail of the patient, of nearly 3,000 patients on it. And that's how it started. And then and I won't say the research funding. I self-funded. I self-funded my fees. Like, unfortunately, sometimes that doesn't. You don't get equity with that.
I can see for each of our speakers that there is a comment in there from AD saying, would you be interested in building a network to review clinical cases in pediatric orthopedic physiotherapy or synergies for research in this field? From Colombia, our group would be interested. I think that that's definitely an intention of the IOPTP for these webinars and other activities to create these kind of networks where there is opportunity for that and mentoring in those areas. So yeah, if Katie and Marie and Fran are interested in participating in that, that might be a nice way for us to kick off one of the mentoring opportunities where we could register people to mentor with you. But we might ask them offline so they've got an opportunity to say no if they're overwhelmed with other things at the moment.
I think we'd have to see how that would go. And a lot of it is about systems and processes because they're different from place to place. And, Marie, Fran, and I are in 3 different countries that have advanced practitioners or clinical specialists. So it is varied. But I think, we have to help each other for doing things like that. So there are some areas that we can influence and stuff like that. And sometimes it's just being able to ask somebody a question. So, I don't know what it would look like and what the commitment would be, but my email is, and I'll drop it in the chat as well. I'm happy to kind of ask questions and cover what I can. And that's fine. And also, if you are emailing me, I'm okay with not an overwhelming bit of social niceties. So don't because time is precious. So you can just be like, please answer this.
The other thing that Carissa, I think, is working on is a future webinar in 2025 about specialization pathways. And so obviously the word specialization can be different in different countries. And has some connections to advanced practice in some countries as well. So we will be doing a webinar on that, which will help show all the different pathways that a variety of different countries have. And I think that will sort of build on this topic as well in terms of people igniting thoughts about what people can do to specialize more and move towards advanced practice should they wish to go down those routes. So hopefully that would be helpful. I do have one more question before we finish. I know we're over time already. I can't help but think, like, we have some loose comments happen in our physiotherapy pediatric practice in Australia where people might say, well, that's not up to us. People with higher levels of insurance will look after that. So i.e. our surgeons who pay sometimes, tens of thousands of dollars in insurance each year. So what insurance considerations have you had to have? Are they covered by the hospital and the hospital looks after that? Or on a personal note, do you need to consider your insurance?
Well, I take this one because it's what I'm working on all the time. Okay. So I actually don't work clinically anymore. I'm the CEO of the Irish Professional Body. And the reason actually I took on this role when the previous CEO retired was just to sort out and finally get advanced practice as we're creating it as a new remunerated grade in Ireland with all the associated legislation. So currently the way insurance works in Ireland, I know it's different in every country. There is no legislation in Ireland around physiotherapy scope of practice. The professional body sets the scope of practice. So the ISCP sets the scope of practice for the whole profession in Ireland. So we have professional scope and we have individual scope, and we have a very clear document. So for the moment, ultrasound, you know, is within professional scope. But if you haven't done, or say injection therapy, because we have a very clear course on that, injection therapy is within the scope of the profession. But if you haven't completed the appropriate course, being signed off on, and be doing at least 20 injections a year to maintain your competency, it's not within your individual scope, so you're not insured. Something has to be within your individual scope as well as the profession scope. And then you either are covered by, if you work in the public hospitals, you're covered by the clinical indemnity scheme, which is for all public practitioners. But if you work in private practice, you have to take out profession insurance. But actually, whenever anybody, as scope extends and new tasks come on, whenever anybody asks the insurance company, am I insured? They come straight back to us and say, do you cover? Is this within their scope of practice? And if they can demonstrate their individual scope and competency, and we say it's within the profession scope, they're covered. Say for example, say after COVID, a lot of physiotherapists in Ireland were trained to vaccinate the COVID vaccinations. And somebody contacted me afterwards and said, I want to start giving like facial Botox now in a beautician's clinic. Am I insured? And I was like, no, because that's not within the profession's scope. You may have learned to do injections, but that's not a scope of practice for a physio. So no, we're not going to insure you to do facial Botox. But if somebody had said, I want to do spasticity Botox and I've done all this, and this is my training, it's like, yes, you are insured.
Great. Thanks so much, Marie. And thanks so much to Katie and Fran and also Carissa for all of your work in planning this webinar. We know we're over time now by 10 minutes. So if you're happy, Katie, Marie and Fran, are you okay if people communicate with you via email if they've got urgent questions that are burning before the next opportunity for us to have a webinar on the specialisation pathways? And also we'll communicate with you more directly about the potential for mentoring, where we might be able to put something up on the website that people could connect with. I also just wanted to mention that the IOPTP website is under redevelopment at the moment. So hopefully by 2025, you'll see a brand new looking website that'll be a bit easier to navigate, and where we've got one of our wonderful paediatric physios who's also got great technology skills, Cherie Ziski, working on that. So please look out for that, and we'll put more information on how you can contact with the or contact the presenters of the webinar. Marie, just you're on mute at the moment. Yep.
Sorry, I'm just going to share that slide again for anybody who hasn't logged their attendance.
So for anybody who missed this at the beginning, we just said if you need an attendance certificate, not everybody does, but if you need one, please go ahead and scan the QR code there and register yourself as having attended the webinar. And over the next month or so, the webinar team will be able to get attendance certificates to you. Okay, thank you very much, everybody, for your attendance at the webinar today. And please keep an eye out on the IOPTP socials or website for upcoming webinars. There should be one more prior to Christmas, and then the 2025 webinars will be advertised from December onwards. Okay. Bye all.